Hi, ladies and gentlemen. Welcome to web seminar of ISCP, International Society of Cardiovascular Pharmacotherapy. I'm Koji Hasegawa from National Hospital Organization, Kyoto. And today's topic is cardiovascular management of patients with diabetes. Diabetes is a strong risk factor for cardiovascular diseases. However, it is controversial whether the strict control of blood glucose level is beneficial or not to prevent cardiovascular diseases. So today, we'd like to ask Dr. Masayuki Yoshida, Professor of Medicine, Tokyo Medical and Dental University, to have a lecture on cardiovascular risk management of diabetes, and we'd like to discuss on this matter. Professor Yoshida, please.
Thank you, Dr. Hasegawa, for kind introduction. My name is Dr. Masayuki Yoshida from Tokyo Medical and Dental University. As Dr. Hasegawa mentioned, diabetes is the major concern for the cardiologist. Today, I'd like to share with the audience the recent and the previous clinical data and think how to cope with this very difficult diabetic complication, especially cardiovascular risk management. Okay, so let's start my talk. The title of the talk is Current Cardiovascular Risk Management of Diabetes. As we all know, every 10 seconds a person died from diabetes-related complications. The complications such as heart disease or stroke, eye complication, and the kidney complication, and extremities complications. So presumably next 24 hours, approximately 20,000 patients will develop diabetes. And the previous study shows that type 2 diabetes is a progressive disease. As you can see these slides, the hemoglobin A1C, which is an indicator of a diabetic situation, is increasing year after year. So it is very important to control the glycemic level. However, recent study shows the low HbA1c targets, which is based on the strict glycemic control, associated with a high risk of a severe hypoglycemia with most of the current treatment option. In this slide, the three clinical trial data are shown. As you can see, there is increasing severe hypoglycemia in intensive control when you compare with the standard control. So strict control is better to reduce hemoglobin A1c. However, it also increases the hypoglycemia. So this is the current controversy whether we should treat the patient with intense control or not. And when we think about the cardiovascular complications, which is also still controversial, this slide shows a meta-analysis of 4 very big clinical trials of the diabetic patients. And when you interested in a stroke or myocardial infarction or hospitalization or fatal heart failure, this top panel and third panel, there is no favor beneficial for the intensive control. In the second column, myocardial infarction is better in intensive care group. However, the p-value is not strong enough. So even for the cardiovascular risk management, intensive care is still controversial, which is better or worse. And more recently, we have a new class of diabetic drug, such as DPP-4 inhibitor or increasing mimetic compound. And this trial, the 3 trial in this black column, showed the result of a DPP4 inhibitor trial. However, 3 of these newer glucose-lowering agents does not improve the cardiovascular risk management. So it's neutral, the similar as the previous one. And the similar results are obtained from this increasing mimetics. And now we have pretty new clinical research data from Empagliflozin outcome, which use the sodium glucose co-transporter 2 or SGLT2 inhibition. This is a quite new class of anti-diabetic drug. The mechanism of this drug is shown in this slide. The major target of this compound is proximal tubule of the kidney. There is a transporter named SGLT2 which reabsorb glucose and sodium from the urine lumen to the blood. So this way the glucose is reabsorbed to our body. Usually in the glomeruli, the 180 gram glucose were filtered. However, in this proximal tubules, more than 90%, approximately 90% of this glucose is reabsorbed. So if we inhibit this reabsorption, the glucose is go in the urine and not reabsorbed in the body. And also, the diabetic situation includes upregulation of this reabsorption. When you compare with a control subject, a patient with a type 1 diabetes as well as a type 2 diabetes, the both increase this renal tubule reabsorption of glucose. So these basic data suggests or suppose and the efficacy of inhibition of this SGLT2. And actually, using this SGLT2 inhibitor, we can increase the glucose excretion from urine. And now I'd like to show you the recent data using this SGLT2 inhibitor called Empagliflozin. The title of this trial is Empagliflozin Outcome, randomized double-blind placebo-controlled cardiovascular outcome trial. The object of this study is to examine the long-term effect of this empagliflozin, the SGLT2 inhibitor, versus placebo in addition to a standard of care on cardiovascular mortality, morbidity in patients with type 2 diabetes. The trial design is something like this. After screening, the patients are randomized and treated with either placebo or low-dose empagliflozin 10 mg or high-dose empagliflozin 25 mg. The key inclusion and exclusion criteria are shown in these slides. The inclusion criteria is adults with type 2 diabetes and BMI less or equal than 445 kg per square meter. And hemoglobin A1c level is 7 to 10%. And more importantly, patients who has the established cardiovascular disease. And key exclusion criteria is eGFR less than 30 ml or per minute per 1.73 square meters. And pre-specified primary and the key secondary outcome is shown in this slide, the 3-point MACE, time to first occurrence of cardiovascular death or non-fatal MI or non-fatal stroke. And the primary outcome of this trial is shown in this slide. As you can see, compared to the placebo group, both the low dose or high dose group has significantly less 3-point MACE after this trial period. And interestingly, this separation of placebo arm and treatment arm is quite early as 6 months of the onset of this trial. The similar beneficial effects are also confirmed with the cardiovascular death as another major endpoint. The both low dose, high dose, this empagliflozin treatment group is much better survival in terms of cardiovascular death compared to the placebo group. So definitely this treatment has some beneficial effect on the high-risk type 2 diabetic patients, which is also the case with the heart failure hospitalization. As you can see from this slide, as early as 6 months of treatment, there is a significant difference between the placebo arm and treatment arm. So this new type of anti-diabetic drug reduce the onset of heart failure in the type 2 diabetic patients. And taken this all, we can show you this all-cause mortality, which is a very strong indicator of this drug. And this all-cause mortality is also beneficial for the treatment arm, the both low dose and high dose group. So after this endpoint analysis, this drug can beneficial in the treatment of the cardiovascular high-risk population of the type 2 diabetic patients. In the meta-analysis of this trial, there is an interesting observation occurred. The renal outcome with empagliflozin. As you can see, progression of CKD is one of the major complications for the type 2 diabetes. And by use of this SGLT2 inhibitor empagliflozin, we can reduce the progression of CKD. As you can see, compared to the control arm, this treatment arm, EGF reduction rate is lower. And incidence of worsening nephropathy is also lower in the treatment group. So development of albuminuria or doubling of creatinine level and need for dialysis, all this renal outcome is better in the treatment arm. To summarize this EMPA-REG outcome trial, as you can see from this slide, the mortality benefit is large and clinically very important. And the mortality risk reduction is statistically robust. And the mortality benefit is based on a large number of events, which is a consistent benefit is seen with both doses, the low dose and high dose. So doctors are curious about why this empagliflozin work for this cardiovascular risk reduction. There is, of course, glycemic control becoming better. And as you can see from previous observation, the blood pressure lowered by use of SGLT2 inhibitor, and weight loss also occurred with use of SGLT2 inhibition. However, in this EMPA-REG outcome trial, the beneficial effect is quite early phenomenon. So both of these three mechanisms need a fair amount of time to clinically observe. So timing is too early for these parameters, inconsistent with other previous SGLT2 or other compound trial. And a quite new recent hypothesis is something like this. I wrote it in the red color. The reduction of intraglomerular pressure of the kidney and the volume depletion of the systemic circulation and the raise in the hematocrit. And these phenomena usually occurred in a quite early phase. So this may explain large prompt effect of this new drug. This is the scheme of renal glomeruli. And in the case of diabetic nephropathy, there is a hyperfiltration occurred, which is based on the dilation of afferent incoming artery and constriction of efferent arteries or outgoing artery, resulting in intraglomerular pressure very high. So this glomerular hypertension causes the glomerular damage, which causes the glomerular death and the fewer nephron available to infiltrate. So further stress for residual nephron. Then the glomerular hypertension is much worse. So this vicious cycle starts when the diabetic nephropathy is progressing. However, by use of this SGLT2 inhibitor, we can reduce the intraglomerular pressure in type 1 diabetes as well as type 2 diabetic population. So this may be one of the reasons that we can get the very early beneficial effect of a cardiovascular outcome in this EMPA-REG outcome trial. And actually, this phenomenon are also observed with other SGLT2 inhibitor apart from empagliflozin. This is the data of canagliflozin, the other SGLT2 inhibitor, also reduce the albuminuria in the people with type 2 diabetes. So one of the current concepts is something like this: the potential pathway linking SGLT2 inhibitors with a lower risk for heart failure. The primal target could be the kidney. When you inhibit SGLT2 in the kidney, the glucose sodium reabsorption is reduced, and urinary glucose loss is increased, which means the urine volume is becoming larger. That makes intravascular volume reduction and hematocrit elevation, and also systolic blood pressure reduction. And these circulating parameters change may influence the cardiac afterload reduction, the preload reduction, and myocardial oxygen supply elevation by virtue of increased hematocrit. And these beneficial effect on the heart or cardiac myocyte may lead to the improved outcome for the heart failure. To summarize my presentation today, I'd like to focus on these 3 points. The number 1, SGLT2 inhibitors are promising anti-diabetic drug to reduce cardiovascular risk in type 2 diabetic patients. And number 2, renal effects and hemodynamic effects may explain rapid beneficial effects observed in EMPA-REG outcome trial. Although, having said that, we'd like to say the number 3, the further trial, ongoing trials such as CANVAS, DECLARE, and CREDENCE will provide more new data for the efficacy and safety of this type of drug. Thank you for your attention.
Hi, thank you very much, Professor Yoshida. He talked about cardiovascular risk management of diabetes, especially focusing on the result of EMPA-REG trial, which showed a dramatic decrease of cardiovascular events by SGLT2 inhibitors. There are some slides on the possible mechanism on the beneficial effect by SGLT2 inhibitors. Is there any additional comment or the possible mechanism on the beneficial effect by SGLT2 inhibitors?
Yes, that is the most important point in my presentation. As I presented in my slide, there is a huge reduction of cardiovascular risk, especially the heart failure. And as I mentioned, this beneficial effects occurs pretty early phase of this trial. So one of the main, I think, mechanisms is renal, the effect on the renal function, especially the glomerular hypertension is reduced by this drug. And compared to the other beneficial effects such as blood pressure lowering or body weight lowering, this intraglomerular hypertension reduction occurs pretty early phase of this treatment. So probably the beneficial effect of this SGLT2 inhibitor may involve this new aspect of this drug. And this beneficial effect may be independent from glucose level reduction and more connected to the systemic circulation parameters improvement. So, so far, SGLT2 inhibitor, of course, are used by most of endocrinologists or diabetic professional. However, from now on, probably more and more cardiologists would like to use this drug to treat type 2 diabetic patients with impaired cardiac function. So this drug is very important.
Thank you very much for your comment, Professor Yoshida. And SGLT2 inhibitors have diuretic action and also decrease the blood pressure. Mm-hmm. And alpha glucosidase inhibitors also decrease the blood pressure. And there is a STOP NIDDM study in which the alpha glucosidase inhibitors not only reduce the development of type 2 diabetes in patients with impaired glucose tolerance, but also dramatically reduce the incidence of cardiovascular events. I think there are common mechanisms. Is there any comment on that?
Yes, that's also a very important point. As Dr. Hasegawa mentioned, STOP NIDDM is a very important trial in which alpha glucosidase inhibitor used in IGT population and reduced cardiovascular risk. And alpha GI, the function, the target is intestine to block the absorption of glucose. And this new drug, SGLT2 inhibitor, block the reabsorption of the glucose in renal tubule. So the target organ is different, but the action is similar to not take extra glucose in the body. So as Dr. Hasegawa mentioned, this semi-similar mechanism may something to do with beneficial cardiovascular events. So probably more and more research necessary to further understand the mechanism of alpha GI and SGLT2 inhibitors. Thank you.
Yeah, thank you very much. Finally, I'd like to ask you about management of patient with diabetes. And blood glucose level control is very important for the prevention of microangiopathies such as renal disease and retinopathy control. But in terms of prevention of cardiovascular disease, how do you think about the strategy, including not only including the control of blood glucose, but also the control of dyslipidemia and hypertension?
Yes, also it's very important point. As Dr. Hasegawa mentioned, the strict control of blood glucose level is important to prevent the microangiopathy development. And this is already proven. However, the cardiovascular risk management is still controversial, which means even if we put the strict control in the patient with high risk cardiovascular risk, type 2 diabetic patients, not necessarily the outcome is better, which is already reported from previous clinical trials. And as I mentioned in my presentation, there is a possibility that hypoglycemia is more frequently occurred when we put the strict glucose control. So probably in terms of cardiovascular risk management, basically it is very important to put the patient in a good glycemic control. However, it's also very important to not to experience frequent hypoglycemia, and sometimes strict glucose control linked with the hypoglycemia phenomenon. So the choice of the drug would be very important, especially important in terms of cardiovascular risk management. The other point Dr. Hasegawa mentioned is dyslipidemia, which is also commonly occurred in the type 2 diabetic patient with high cardiovascular risk. The current Japanese guideline for the lipid management for the type 2 diabetes is slightly weaker when compared to the other global guideline. Some countries already regard type 2 diabetes as a secondary prevention. However, in Japanese situation, the type 2 diabetes is still high risk but primary prevention group, which reflect on the LDL cholesterol level, the target LDL cholesterol level. But this LDL management also may be reanalyzed, reassessed by current or future clinical trial, since we have a new type of anti-LDL lowering drug in our hands recently. So this dyslipidemia management also can be modified in the future. So taken all together, I think the type 2 diabetes is one of the most important category for the cardiologist to prevent their cardiovascular event. So we as cardiologists should learn more and more about the diabetic treatment and the mechanism of action in the future. Thank you.
Yeah, thank you very much. I'd like to conclude this session. The important thing is in the control of patient with diabetes is to reduce the complications such as cardiovascular diseases. So we have to consider about the total management, not only the blood glucose level, but also the control of dyslipidemia and hypertension. And SGLT2 inhibitors possesses diuretic action in addition to decreasing the blood glucose levels. The mild diabetic patients with cardiovascular complications are often encountered by cardiologists. So we like to send an important message not only to diabetic specialists, but also to cardiologists to appropriate use of SGLT2 inhibitors may be beneficial to prevent cardiovascular disease. Thank you very much, Professor Yoshida.
Thank you.